Presentation number 22 for the Retroperitoneum, prepared by Prof. Sharaf and revised by Prof. Hanisami. This is the appearance of what we know as pseudomyxoma peritonei. Multiple gelatinous-like myxomatous deposits are seen in all peritoneal covering of the liver and in the falciform ligament and around the stomach, and filling the almost the whole peritoneal cavity, replacing the fat planes. Pseudomyxoma peritonei. Mesothelioma of the peritoneum and mesentery. The loops are converted into a very thin-walled linear structures surrounded with the masses on the mesentery, and these masses are not gelatinous like at pseudomyxoma. It is solid masses encasing all the loops, and this is peritoneal and mesenteric mesothelioma. It is similar to in behavior to mesothelioma of the pleura. Of course, so long we are in the peritoneum, we have a lot of lymph nodes, and these lymph nodes may enlarge and cause diffuse peritoneal lymphomatosis, which again encases the loops, but the density here is different from the density in mesothelioma. Till now we have discussed the pseudomyxoma, gelatinous-like solid material, low density. It's encasing irregular outline of all structures, invading all spaces of the peritoneum. The second is the mesothelioma, solid masses. The third is lymphomatosis, and lymphomatosis by definition is lymphomatous tissue, so its density is very low and has the characteristic appearance of encasing the small intestinal loops, which are converted into very thin tubes, very fine tubes like this. But lymphoma can result in retroperitoneal masses as well, not only in the peritoneum, but retroperitoneal masses can occur. So we have retroperitoneal lymphoma and extraperitoneal lymphedema. We have here stranding of all retroperitoneal structures, garrota fascia, and on either side, and perirenal fat, all is edematous lymphoma. This is the appearance of the leaking aortic abdominal aneurysm extending to the anterior pararenal space. This is the anterior pararenal space, separate from the kidney by this line, which denotes the garrota fascia. Again, posterior pararenal space here is secondary to an infected leakage of the aortic aneurysm with air formation. So this is infected, leaking aortic aneurysm. This is aortic aneurysm, and this was a hematoma which is now infected and extending into the right posterior pararenal space. This is the site where garrota fascia, and further up you will find the kidney. Of course, the kidney can show all images of and varieties of trauma, including hematoma. This is a retroperitoneal structure. But the lymphoma of the kidney can produce more than one picture. It can be presenting as large nodule or multiple nodule encasing the kidney, or subcapsular and capsular thickening, generalized thickening, which is seen on either side, or perirenal mass filling the whole space and encasing the kidney. So these are the 4 appearances of perirenal lymphoma. This nodule could be lymphoma, but is more likely to be deposits. These are perirenal deposits, one here and multiple there. Perirenal deposits. A renal cyst can push loops forward. This is displacement by renal cyst. Psoas normal, psoas abnormal, is large, filled with fluid and containing air, so this is a psoas abscess. The psoas abscess or iliopsoas abscess extends downward to involve the iliopsoas muscle and fascia, and may extend forward through the inguinal canal to fill in front of the upper part of the thigh, proximal thigh. So this part is the same, this is extension of this. This one is extension of this one and that one. Iliopsoas abscess can result starting from the psoas muscle and extends to bulge at the inguinal region, with of course gas formation denoting collection with gas formation denoting gas forming, or denoting perforation of a viscous, or denoting abnormal air location due to injections or aspiration. Colonic changes in perinephric abscess. Then if there is a perinephric abscess, we will find that the function on the right side here is markedly diminished, at the same time that the descending part and ascending part of the colon and cecum are markedly attenuated and irregular, with coarse mucosal pattern due to the presence of perinephric changes. Cholecystitis can produce colonic changes sometimes as irregular outline and displacement or indentation, but here the symptoms is that of the gallbladder. Now you are not seeing such things because of ultrasound, and cancer sigmoid may perforate, and you can see some air coming out in an abnormal position, and here this is fistulography reaching to the sigmoid colon where the perforation is there. Cancer sigmoid. An abscess, a pelvic abscess, can produce attenuation of the rectum and rectosigmoid, displacing it against the sacrum, and here you can find some attenuation with coarse mucosa. The coarse mucosa is due to submucosal edema. A lesser sac abscess can show as retrogastric big collection with air fluids, with air and fluids, and if you give contrast, you will find contrast is seen as a collection, and here in a plain film erect there is fluid level in collection, and here behind the stomach there is air, and here behind the stomach there is air and air fluid level and the collection. So these are the, of course this is after injection. These are the appearances. This is a retrogastric again, air formation, different shapes and different appearances of lesser sac abscess. Something pushing the stomach forward, pushing the stomach downward, pushing the stomach to the left, and the region is filled with fluid, with air fluid, and sometimes it appears in the CT without air as hypodense areas, and if injected it will appear like this, and air is seen here delineating behind the stomach. Lesser sac abscess. This post-operative process, esophagus dilated, jejunum, so it is removed, the stomach is removed, and there is esophagojejunostomy with leakage and resulting in left subdiaphragmatic abscess formation. If you look for this one, there is something strange here. It's not air, not taking any shape, and this one is linen, part of a linen, part of textile, and this again is the same. So these are the towels and sponges seen in post-operative changes sometimes. Peripancreatic nodal enlargement could be due to lymphoma, metastasis from gastrointestinal adenocarcinoma from breast, kidney, or from granulomatous. It may be difficult to distinguish from the pancreas due to thin patients or bulky adenopathy. So if this is a mass, retroperitoneal mass, bulky mass at the root of the mesentery, bulky mass root of the pancreas, lymphoma, bulky lymph nodes encasing vessels, replacing and pushing the pancreas, you cannot define it, and this at the region of the head. So the presence of larger lymph nodes can be sometimes hiding the pancreas or invading the pancreas with the same process of disease like in lymphoma. Pseudoaneurysm with clotted blood. This is the lumen, this is the clotted blood, the hematoma and fibrosis and neoplasm. If hematoma or retroperitoneal fibrosis or retroperitoneal neoplasm, a carcinoid mass at the root of the mesentery with congestion of this root. The differential diagnosis includes sclerosing mesenteritis and carcinoid or desmoid. Sclerosing mesenteritis, carcinoid or desmoid. For this one, this is a large desmoid tumor, and for this one it is a carcinoid, and for this one is a fibrohistiocytoma. One of the famous tumors to be considered in case of abdominal masses, not only lymphoma, but fibrohistiocytoma is another possibility. So if we involving the retroperitoneum, so you should differentiate first whether involving the peritoneum or retroperitoneum, as the process is sometimes confusing. Thank you.